I guarantee you will get better results from your IVF or whatever you offer patients if the male gets seen first. Because we'll get them out of hot tubs, we'll do all this stuff.
I know. I think what's also really exciting, if you get the male patient seen at the first appointment and tested, unlike eggs where you really can't unfortunately change the pace of aging, it's really exciting to see changes and improvements in sperm quality.
You went orange today.
It's fall.
Yeah, it's fall. Like we're 3 or 4 days into fall.
I have to say, I have a moment. I'm an East Coaster like you.
Yep.
And I miss fall.
Yep.
And when the word autumn doesn't exist in LA, right? There's no autumn in LA.
It's true. It's true.
But last weekend I took my daughter to college in Oregon and went through Klamath and Mount Shasta and all those areas and saw fall and the crisp colors and the crisp air and the colors. We did it in her vintage station wagon, 1,000-mile road trip for 2 days. It was fabulous. Imagine spending 2 whole days in a car with your 20-year-old daughter. And
there was
just
a conversation happening, and
those moments are just
bonding
magic.
over
just
that.
Magic. And their cats in the back, loving it.
That's awesome.
So it was a wonderful week.
So you were taking her to college?
Yeah, I take her in her old car because we get her car up that way.
Yeah,
and she loads it full. It's 1,200 pounds of stuff.
I think I saw this car. It's like an old school station wagon.
It's an old school wood-sided.
It's got the wood-sided station wagon. That was my first car.
Yeah.
My first car was a
It's got the
Buick.
Third row back seat.
Yeah, the
facing
backpack.
out.
Yes, I call that the backpack, or we did when I was a kid.
Yeah.
So ours was a Buick Estate wagon, mint green with a wood paneling. And when I was 16, that was waiting for me to. That is a sex killer to any young man. No matter what, get me out of this Buick.
Car shows in L.A. and everyone loves it because it's this, 6 foot tall 19-year-old driving this vintage car. 1990, I think.
She's gorgeous too. So let's just.
It's cool with her.
She just gets out of the car and people are like, "What? Excuse me, who is that steps out of the state wagon?"
It's pretty
right?
fun.
I've never driven totally
California,
all the way up.
San Joaquin Valley, not great, but as soon as you hit Northern California, there's rice fields, and then you hit Oregon. And it's just stunning.
See?
I mean, it's like everything's a postcard. Everything through your windshield. In fact, all the windshield photos have the Buick label with the road.
That's awesome.
But we've done it a half dozen times now.
So speaking of the fall, thank you for bringing that up.
I love fall.
I am wearing my Dodgers hat today because the Dodgers clinched the Western Division yesterday. We were just saying that we'll probably have men listening to this podcast. There might be some guys that actually care about sports. And I am one of them. And so the Fall Classic, which is what they mean by the World Series. So every fall in October, the Dodgers are always in it. I'm a huge fan. And so last night they clinched it. I was at a bar last night with my friends. It was old school. You don't do that on the West Coast. That's more of an East Coast thing.
East Coast, yeah.
But we watched the game. They clinched it. And I said, in honor of it, I'm wearing my Dodgers hat on my show tomorrow. So that's what we need to do in L.A. When in L.A.,
yeah, I mean,
BLA.
You can find autumn.
You can find autumn. I don't think the seasons are cooperating, right? Like it's like summer for LA is in September is the hottest.
Yeah, it's
the hottest time is September.
It's autumn, summer.
And then all of a sudden, a week later, it was freezing. Today it's foggy, and you're wearing a sweater. So.
That's great.
Anyway, hey, today on the show we have a really exceptional guest. Her name is Dr. Janet Choi. She's the Chief Medical Officer of Progyny, and we're going to talk all about what she does and who she does it for. She's a reproductive endocrinologist,
IVF doctor, yeah.
which means she's an IVF doctor, but she's kind of advocating now, similar to our guest Neil Shah last time, for fertility health.
Yeah.
So we're big fans. But we'll get to our guest a little bit later. A little bit of business that I want to take care of, if that's okay, because this is our 3rd episode. So we need to make sure people know where to find us. We need to make sure people that are listening are sharing, right? That they get that we're a bit missional in this podcast. Missionary. Well, that's a different. What did we say? That's episode 14.
Sorry.
We're going to talk about missionary.
That's right, the sex positions episode.
We should do that. That's a really good question. I don't know. Do you teach those? Is that like you have a class on Wednesday nights? Okay, so business of the podcast. So the podcast is up. This is our 3rd episode. We are on Apple Podcasts. We are on Spotify. By the way, on Spotify, it's audio and video, so you can kind of decide if you're going to watch it or not. Then we're on Amazon Music. We are on YouTube for sure. So please like, follow, subscribe, get the word out. We're going to sit here and talk week after week about this stuff, but unless people hear it, did it even happen? Right? So let's share it. Let's share it.
We're legends in our own minds. I mean, time.
Okay, so the last thing I want to talk about before one of the things I want to talk about before we get to our guest, because my Facebook is kind of blowing up.
Oh.
It is the 4 hymns kind of phenomenon that's happening. This medication that I can get through my phone that is going to do multiple things for me in my sexual health or in my fertility or in my sexual life, my rejuvenation. So tell me a little bit, just as the doctor that I would go to, should I be just getting, is erectile, let me go specific.
Are you asking whether it's safe to buy medications online without a doctor?
Thank you.
Is that?
Yeah, sure. What do you think?
It can be, but there's also risk. Right. So, for example, it's prescription medications are prescription for a reason because they have side effects, and they're contraindicated or not to be used in certain scenarios. So you have to make sure that you're not one of those you're not excluded for those reasons. So that usually takes a doctor or a provider to do it. So some of these companies online do have a provider, but they don't do essential things like physical exam and stuff like that. So you will miss, since erections, for example, are the canary in the coal mine for metabolic and general health, you will miss diagnoses that you could pick up, like, for instance, diabetes. So if you have diabetes, it may be subtle, you may not know. You have an erection problem, you fix the erection problem, you still have diabetes. You'd be better off fixing the diabetes. And there's about 20 or 30 conditions like that you'll miss. In
a teleconference with one of their doctors, they're just not going to ask you all the right questions.
Right, so they're going by the rules, which is to do their due diligence in a way, but it's not complete and it's often cursory. And so things will be missed that could be helped because it is a canary in the coal mine. So that's the whole idea. This is one way to get men into medicine. And doing it online cheats the system a little bit, but in most cases it's probably okay. You also have issues of complications and side effects. Who are you going to call if it doesn't work out?
There's 2 different kinds of kind of product that I'm interested in. Not maybe me personally, but there's one where there's one where I can't get an erection or I'm having a hard time, right? Erectile dysfunction. And then they are advertising for lasting longer during sex. Is there a medication other than the little blue pill that is, I mean, obviously it's now on the market for generics and for hymns is saying that I can last longer if I'm taking their pill? What do you think about that?
I think that's the same pill.
Ooh, really?
Yeah, I mean, different versions of the same pill. They do both. They help you get an erection and they help you keep an erection.
Keep an erection.
There's nothing
But they don't help you keep you from climaxing early.
So there's erectile disorders and there's ejaculation disorders.
Okay.
So there's pills for both. Ejaculation disorders are I'm too early, I'm too late, it's not happening. Right?
Okay.
So early, late, or
not happening.
Pre, delayed, and ejaculation.
See? This is what I'm talking about.
Right.
I would have said that.
So there's something for early ejaculation. There's not much for late ejaculation that works. And ejaculation is a whole different issue that needs medical care.
Late ejaculation sounds like a healthy problem to me. Sounds like a great problem so that I can satisfy my wife in bed and I'm getting to this.
Okay,
I want to get
turn.
Right, but let's get into it. If I am a guy that is not I'm ending too soon, so my wife is not orgasming. Then you're saying I could take a pill to make me stay hard the whole time, but I'm saying like to actually make me last longer so that we're
So early ejaculation can be lifelong, where you have no control, because ejaculation is a reflex, like you hit your knee or a sneeze.
A sneeze is a
And
good
if
way
you
to
don't
say
know when that's going to happen, you might get caught up in it because it's so fast, right?
Yeah.
So it's a nervous system that's really jazzed. And you have to delay. You have to either figure out when that's going to happen and back off.
Yep.
And so the most common way to do it is to take local anesthetics where you numb the penis.
I've heard this. I've seen a product.
Or pills like
Okay.
antidepressants that tend to reduce the sensation. And then, but if you don't learn to get control and hit the ball on the line every time, you got to kind of practice that. It's still not that great. And there are a lot of side effects from antidepressants taken for early ejaculation.
Okay, so
that's what they kind of offer in these online things. But I have a better solution.
Okay.
I mean, I use a good sex therapist, and you teach them to hit the ball on the line.
right. Well, that's what I was
It's
saying.
called behavioral therapy. It usually comes from doing it the same way for so long, and it's just, your golf swing isn't very good. You have to relearn your swing.
There's not a pill for a golf swing either. Men just want to be able to pop a pill, and then all of a sudden they're a porn star, right?
So
right, that's what they want. I mean, so I get it. I understand that issue, and you're saying no, it's really a behavioral therapy or a physical therapy. It's curable, but it takes. I will say the same thing for weight loss or exercise we've talked about,
work.
right? So I could take a pill. I mean, Ozempic's huge right now. I could do the things that it takes to do it with substances, or you could just not eat and exercise, right? And like you could train your body to
Absolutely
correct the problem.
I asked second question I asked them, if that's the problem, is how motivated are you?
There you go.
Do you want a patch or do you want a cure?
Okay.
I come from a German craftsman point of view, which is do it once, do it right, fix it. And if you empower a man, if he can do that, he'll do other things. He realizes, I can do the personal work to get this done. I could also lose weight. I could also improve this. I could also do better at that. It's empowering. It's part of the empowerment that I like to see with men.
My sex life changed drastically when I lost weight, clearly. So when I weighed 325 pounds. I'm going to say this. I saw this on Dr. Oz like 25 years ago. Okay, Dr. Oz was talking about losing weight, and he said, when you lose weight, if you're a man and you're significantly obese, and then you lose all the weight, guess what happens? Your penis gets bigger. And I was like, what? But
what happens is the fat behind it.
Thank you.
goes
So
away.
everything else
It's
shrinks
apparently
down, and you
bigger.
realize that it's one size. It's always been the same size. It's just in proportion to your own body, it's bigger.
And when I see
essentially.
men who are obese in the office and they say my penis is shrinking, I'll put a ruler in through the skin and say, well, that's because 4 inches of it is under
smokes.
fat.
Well, at least I got 4 inches of it.
Right. So
Right.
I said, you actually fine.
Yeah, you're fine. That's another one. We could get stats on actual
we have
lengths
those,
of
yeah. We
penises
have
and all that stuff so that guys can understand that,
Most of them are fine.
see, most of them are fine. I think that's what ladies say too. It's fine. Right?
We have to do that episode.
This show is not a show about fertility, and it's sexual health as well. I want to.
Well, I'll do one example.
Okay,
a
good.
really important paper was published where women had computer contacts on which watched their eye movement. And they were shown pictures of men with different shoulder widths, height, penis length.
Mm-hmm.
They're constructed computer. And they watched where the women looked the most. And not what they thought, not what they felt, but where they looked the most.
And
And they were trying to determine if there was a penis size that was most attractive
it pulled
to
their
women.
attention. Yeah. Okay.
Right, the
Yeah. Yeah.
The most attractive penis size to women ended up being about the average length of the American penis.
What's the average length of an
I
American
think it's
penis?
12 centimeters flaccid and 16 centimeters.
Can you do
long.
the
It's like,
American mash? What's the math on that?
2.5
16
centimeters.
centimeters?
About 4.5 inches.
Okay.
Or 5.5 inches erect and 3.5 inches not. So there's growers and showers, right? So it's different. So some men look naturally, flaccidly, very large. They don't grow as much
Right.
as showers. Showers don't grow as much as growers.
Right.
Right.
But
anyway,
I've had this conversation.
What
so
really
this is
mattered
on the
was
non-doctor
not
side.
the penis size. It was the ratio of shoulder to hip. It was the whole physique that really drew them in.
Look, we are just scratching the surface of penises, and I think I'm gonna, Jennifer, I want to do a show on penises. Like it'll be the penis show someday. Men talk about this stuff jokingly. We talk about it in society about how large it is, how large it needs to be. The grower and shower thing, that's awesome.
Yeah.
That's like shrinkage.
There's a paper on the percent growth in showers versus the percent growth in growers. And it's substantially different. And actually, one of my colleagues wrote the paper. It's really a cool paper.
I'm very interested. So I need to read that paper. I'd like somebody to get me the paper.
It's so funny. Guys will often say in the exam, they say, I'm a grower.
I honestly went from being
then the
a
showers
grower
just
to
go
a
like
shower.
this.
The showers just stand there. Okay, well, we could talk about this all day, of course, but we need to get to our guest. We do have a guest today, and we're not going to be able to talk about growers and showers with her because she's pretty high level. Is Dr. Janet Choi. She is the Chief Medical Officer of Progyny, which is an employee benefits company that helps men and women build families through IVF, fertility, like things we talk about. One distinction that we want to make today is that Progyny is including men in their process.
Right, and that's novel
in
America.
Thank you, and we're gonna thank Dr. Janet Choi for joining us today.
Yes.
Everybody, welcome. Good morning, I guess.
Hello,
it is.
Janet.
Hello, good morning.
Good morning. So before we get started, if it's okay, I'm going to read this bio and just kind of sit in it, listen, and feel proud because you have built quite a career. Dr. Janet Choi is a board-certified reproductive endocrinologist and serves as the Chief Medical Officer for Progyny, where she brings her expertise to ensure Progyny provides the highest quality fertility, family building, and women's health services to their members and continues to raise the bar as an industry leader. She's written and published and lectured on fertility and oncofertility. Can you guys tell me what's oncofertility really quick? I just want to break in.
Yeah,
what is onco?
Basically trying to help those individuals who might not be ready yet to start a family. Unfortunately, recently diagnosed with, you name it, some sort of cancer, breast cancer, testicular cancer that may require therapy that could impair their future fertility. So if in consultation with their oncologist, there is some time to work with, trying to offer them services to give them hope, to give them a little more future control, whether it's sperm freezing and banking for future use, or for women with these diagnoses, trying to freeze their eggs and or embryos to try to, if they run into future fertility problems, have something available to help them.
Yeah, it's pretty intense. It's like you're in the Indianapolis 500 and there's a timeline and you've got to do it quickly and there's hormonal sensitivities. It's pretty sophisticated because breast cancer is hormonally sensitive. You're giving hormones to get eggs. You're on a timeline. So it's a lot of orchestration between doctors. But it's a fabulous field.
You used to be the director of CCRM in New York, which is a fertility clinic, correct?
It is.
And one of the largest. And so what takes you from going from that to Progyny?
So there is a nice little bridge there. I actually started off in clinical work over 24 years ago at Columbia University in the city on faculty there. And served there seeing patients and kind of helping with research for about 12, almost 13 years. And what I found very quickly, the thing that I appreciated most as a doctor, and I think having heard Paul speak on his prior podcast and reading some of his blogs, I think this will make sense to you. The part that I really liked most was working in tandem with the patient population, being able to have a conversation with them, educating, both me educating them and actually them educating me along the way. And one of the big frustrations, especially with a great university like Columbia and a system where you take all payers, all insurance plans, is that the time that doctors were allotted to patients got whittled away until it went from like 45 minutes per patient, 30 minutes to 10 to 15 minutes. And so the opportunity to join up with this fantastic network that Dr. Bill Schoolcraft founded decades ago, CCRM, with his lab services and with 3 other wonderful physicians and a whole team of nurses and admin people, where I could actually control my time better, spend literally 45 minutes to an hour with a patient if necessary, and also spend added follow-up time, made a world of difference. And that's where I learned when I was working at CCRM from my patients about 7-8 years ago about the beauty of having a really comprehensive benefit. We'll go into that later, but Progyny And so I ended up joining or being invited to join their medical advisory board. And so continued my clinical work for 100% of the time and served on the advisory board for Progyny. As Progyny grew and as my sort of desires and focus shifted a little bit, I wanted to be able to serve more people. Our goals aligned very nicely. And so when they said we need a full-time medical director, I was like, I'm game to try if you're willing to take me on. And it's been a really wonderful experience since I joined last year.
I mean, I do love physicians and other leaders in the field who see it as their obligation to make a bigger contribution. I really think that's important, and I love the drive that you have, Janet, to do that.
I think it's got to be a hard decision too, because one-on-one, you're personally affecting that person, right? And you're giving all of your knowledge and your education and your expertise to this person to help this person. But there's millions.
Exactly.
And so now you can exponentially 10x yourself or 100x yourself in the position you're at. So it's probably a tough decision to have faith that it's going to be effective on the level as opposed to that one person you want to see on a daily basis.
Exactly. And at the same time, I think I feel fortunate because with this team, we're impacting millions of lives. And I still remember one consultation that I had where a couple had literally 7 years of infertility, and they had scraped together money to see me because I think she worked in a grocery store. And that's when I was like, I want to just make sure that as many individuals like this person, like this couple, have the proper insurance plan and coverage so that they don't have to scrape out all of their savings to go see a fertility consultant.
So at the end of your bio, it says you were magna cum laude at Harvard University. So I don't want to also pass that up, but it was in English literature.
That actually was, my parents accused me of underachieving there. So there was a moment of shame there at graduation when they're like, you could have done SUMA, couldn't you have? So I love reading, loved, and back in that time, Shakespeare and Milton. So I wrote a thesis on Milton's Paradise Lost, but found very quickly that if I followed the academic professorial literature track, it was kind of lonely. And I didn't feel like my life mission to like help people, it didn't align as well. And so when I was thinking about other options, again, I like to be prepared. I was also doing pre-med work along the way. And having had two parents to follow and look up to who are both immigrants to the country and physicians, it made a lot of sense to go to medical school.
What do you think you would have been if you weren't a medical doctor? What do you think you would have been?
It's so hard to know because, my like sort of life mission or view changed and shift all the time. I mean, back then when I was sort of struggling, I worked as an English teacher for a while. I worked in a kitchen in Boston. I really loved cooking and the team camaraderie, and so contemplating going to culinary school. But really happy that I ended up choosing the medical field.
We ask our guests and their teams some stuff, and we said, we want to know a little bit about you. And she was like, well, so we asked them, what would you geek out about? Like, what's your thing? And what did you tell us?
I like to geek out when I go to a new city, whether it's domestic or abroad, a new place to explore. I like to geek out and investigate, much to the chagrin of my husband and sons, where the best coffee houses. Because I am unfortunately,
she's a foodie.
Yeah.
I'm a caffeine addict. I'm always looking for the best, darkest, deepest espresso.
So we should travel with you is what I'm hearing. Yeah, we want to travel with her. Janet, she's going to tell us where all the good restaurants are. Well, let's get to talking a little bit about.
I have one more question for Janet.
Please.
Is, what's your biggest contribution, or what do you think the most important thing or your bucket list item is in the field or in life? You've done a lot.
You've done a lot. What are you most proud of?
I wasn't really brought up to kind of celebrate my individual accomplishments much, but I think my contributions to the teams I've actually had the good fortune to work with, starting off with, back at Columbia where I was a med student resident, I was really fortunate to work with some wonderful nurses and professors and colleagues, and the patients we were able to impact there, particularly with the fertility preservation oncofertility program that I helped co-found there, and the hope and the promise that we gave to a lot of women. And then also the impact that I was able to have with my team at CCRM. Again, trying to help as many people with their struggles, trying to support them and offer them solutions. And if things didn't work out, because unfortunately medicine frustratingly doesn't yield 100% perfect results all the time, trying to promote some sympathy and compassion there. And then I really think, again, having found this incredibly driven, mission-focused team at Progyny, that the ability to, even though it's not a one-to-one conversation or a two-to-one conversation in a patient in a doctor's consultation office, knowing the impact we have on so many people. I was on a flight recently, and one of the flight attendants actually came up and said, "I just want you to know, because of Progyny, I'm now able to actually have a child and afford it. I couldn't afford it in the past, so thank you so much." And so that kind of impact really gets me up in the morning and really kind of gives me drive to move forward.
That and a quad espresso.
And a quad espresso.
In my old age, it's down to a double espresso right now.
Look, you are. We're hoping that this Progyny path and what you just said is the thing you're most proud of down the line too.
Yes.
Like we look further down the line and go, wow, look at what we've accomplished.
I would vote for that,
Yes.
especially for the guy thing.
So tell us what Progyny is, so people that are listening can really understand what Progyny is doing.
So Progyny started off when it launched as a fertility family building solution because there really wasn't a great option at all. Incorporating not just administering the insurance benefit side, but making it as comprehensive and equitable as possible for all to recognize there's not just one straight path to trying to add to one's family. There are a multitude, whether you're a single parent by choice, same-sex female, same-sex male couple, heterosexual couples struggling with infertility, and also incorporating in all of that all the potential treatment requirements of patients. And while I'm sure you've seen this over and over again, I would have patients with more traditional carrier model coverage or no coverage whatsoever not only come in with the whole burden of having this medical diagnosis of infertility, but also struggling with that added burden of trying to figure out, could they afford the treatments that they needed to actually have a child? And so having this sort of solution and actually trying to help eliminate as much as possible the financial concerns really makes it a lot easier, both for the doctor to do their proper doctoring and for the patient to work collaboratively with their doctor and their care team to sort of make really wise clinical choices, safe choices. And so then taking that expertise lately, because there's been such a demand for continuing Progyny services even after one conceives, or even if they conceive without any medical assistance, because one of the heart of our programs that I really feel strongly about is our patient care advocate program. So each member is treated like they're a concierge patient. So every time someone signs on, they're matched with a Progyny patient care advocate who might have been a nurse in a former life, or an embryologist in a former life, or an LCSW or doula, to help guide them along the way and fill in the gaps, especially when the doctor may want to be there for them day in and day out, but just they don't have the time because they have so many other patients they have to take care of. So we took that and expanded that into other areas of women's health care that we thought could benefit from added support. So menopause support and pregnancy, postpartum coaching and support. And again, I know we're going to talk about the male factor as well. But
tell us about the philosophy behind that.
I think
please.
maybe a little backdrop, like what's the deal with insurance and fertility in America? Because what's the need? I mean, this is a great example of a patch or whatever, a solution. But
right.
What's happening in general?
With insurance, typically the larger carriers will offer some sort of fertility coverage, but there's a dollar cap, which again, as a clinician, I saw over and over again, the worrying about time and money running out oftentimes compelled patients to maybe not make because it is a shared decision model nowadays, not making the safest or best clinical choice or medical choice when faced with fertility treatment needs. And then a lot of these insurance carriers, the way it's structured, there are a lot of restrictions. So case in point, I still recall one same-sex female couple that came to me because they were really excited. Their employer was finally offering fertility coverage. And I had to sort of pop their balloon because I said, unfortunately, my team just explained to me that in your plan, you first have to prove that you have failed 6 donor insemination cycles in a doctor's office before any fertility coverage will kick in. And that
6.
blew their mind because
Yeah.
we were both over the age of 35, and age really affects especially female fertility. And they were furious, which I totally got also. So there are iterations of coverage, but unfortunately not really equitable and not really comprehensive, and not really also with a really important part of patient education understanding along the way.
So what you're saying basically is that that insurance coverage or benefits for infertility care has been a mishmash in America. There's 15 states that mandate care for infertility. And we got to go back to a different question, which is, why is that? I mean, you have a medical problem or an injury, you get covered, COBRA, whatever, and there's federal insurance and state insurance and private insurance. But why is infertility not covered? And I think the reason is because it's only recently been designated as a disease. It used to be something that happens to you or someone you know, too bad, unfortunate, it's too bad. And it was kind of a peripheral to medical, to health. And now we know it's integral to health. But I think it was 2010, the Center for Disease Control designated infertility, the WHO, World Health Organization, designated infertility as a disease for the first time. And I think the ASRM, our National Society, American Society of Reproductive Medicine, designated it about 2012. That's only 10 or 15 years ago. For the last, 100, it's been considered something else. So that's probably why insurance, it's not a disease and it's not medically necessary to cover it. And
I mean, I'm just saying it out that I think there's definitely a part of the whole culture that we have to, this is a little peeling layers off. You all are making strides. The conversation is happening.
That if it's 10, 15 years old, that it's just been a disease, you can see why insurance has been a mishmash of cover it or not. We can get out of it, we won't. And then Progyny comes along and says, and that's what.
And specifically for us, you're including men. So
absolutely,
tell us a story. So another quick story.
What's the fertility benefit stuff?
There you go. What are you doing for? What do men get in a Progyny
situation? What's very exciting is what we realized after talking to our patients and to our doctors in the network, our REI doctors, is thankfully the recognition that especially for heterosexual couples struggling with infertility, it's not just female factors, as Paul knows very, very well. At least 40% of the time, there is a contributory male factor. And that the male factor, even though as a reproductive endocrinologist, I do know how to do a testicular exam, and I do know how to at least order a sperm analysis.
Say it ain't so, Janet.
But I would prefer, I think, to optimize the efficiency of getting the right medical treatment in place and the right testing done. My preference, as would be my REI colleagues' preference, would be to work collaboratively with a experienced reproductive urologist, somebody who has not just gone through that very long, arduous training course of being a urologist, but doing further training either through life and work experience, taking care of male fertility patients, or going through a fellowship where they really focus on this as their subspecialty, so that the male can get the proper care from time zero and not find out 1 or 2 years later. I think, Rob, I heard on one of the podcasts that there was a delay in your diagnosis too, which is really frustrating when I hear that. When really I think that both partners should be getting tested the minute they have any kind of fertility concern and see the right doctors.
Yeah, I'm going to pat myself on the back a little bit because I was one of the first physicians that Progyny approached to help architect the male benefits package. And that's a bucket list thing for me to get involved with that, because that's a very significant thing for America to have a consistent plan for men to get coverage. And, we're talking 1/3 of the problem. So I remember when I was lecturing in Spain, or now it's Germany, they have a single payer system, and usually they cover the diagnostic. So they see an infertile couple, this was 20 years ago, and the guy gets seen first. because it's 30 to 40% of the problem, and because the evaluation is a visit or two and a couple $100, and it's a third of the problem, it makes sense for the system. And I've had this talk with Progyny. You're going to save money because you're gonna cure a man, you're going to diagnose him with a problem, you're going to keep him living longer, and you're going to do fewer IVF cycles. Another really interesting fact was one of your colleagues at Harvard published a study in the New England Journal that said, if you look at covered states, there are 15 covered states, and look at the outcomes with IVF, the pregnancy, they use a lot more IVF if it's covered versus not covered. And the IVF cycles have lower pregnancy rates in states that are covered versus not covered. So it's an interesting sort of phenomenon about...
Coverage good?
Well, coverage was only for female.
Right.
Right. So the backstory is that the coverage was really only female. So the guys weren't getting seen. They were going earlier to IVF, and those results weren't as good as the uncovered couples who probably got more male care, right? And they didn't go straight to IVF, and they probably didn't need it. So it's a very interesting deal when you just cover the woman and you avoid the man. There's a lot of evidence that you're going to get better outcomes if you cover the man. You're going to do maybe less IVF.
You agree?
You're going...
I do agree, because again, it takes an egg, it takes a sperm, and if you're not really optimizing the health
Team sport.
of the sperm, right?
Well, in my own personal fertility story, we jumped right to IVF, and then flashback and we're unsuccessful. We didn't have money to do more than one, so that was it, and we were unsuccessful. But then later found out it was my issue, and we could have probably done IUIs. We could have probably done a less. We probably could have not had to do IVF
naturally,
and we ended up conceiving naturally. So that, but I'm just saying that what's poignant about what you just said was the states that have insurance that covers fertility have a lower birth rate.
Female fertility,
right? And so there's a missing.
So like Germany
element.
Covers both,
Yeah.
and they look at the guy first,
Right.
And they do very well. It's cheaper for the system,
Yeah.
It's better for the care. In America, we started out with just female coverage.
We're treating,
and we're going, a lot of it, especially in Boston, Hornstein publishes, Mark Hornstein, it goes straight to IVF.
Yep.
And because it's covered. And that's not necessarily the best way to get pregnant. But adding, folding in a little male factor is probably going to make a big difference. When I was working with UCSF and other programs, I would say, I guarantee you will get better results from your IVF or whatever you offer patients if the male gets seen first, because we'll get them out of hot tubs. We'll do all this stuff. We may even avoid IVF.
I think what's also really exciting, if you get the male patient seen at the first appointment and tested, unlike eggs where you really can't unfortunately change the pace of aging, you can't change their quality. With males, and it's really exciting to see changes and improvements in sperm quality. So I hope I'll get to pepper you, Paul, with some more questions about what lifestyle measures really do help improve sperm quality. Because, I still get excited when I think about some of these couples where I've encouraged, the male when he finally came to the office to maybe think about cutting back his alcohol intake and his marijuana intake, and miraculously over 6 to 9 months. So real improvement in the sperm quality, so they actually finally, after years of infertility, succeeded in getting pregnant.
This is a very interesting topic. Should we go there?
Please.
So, you do encourage lifestyle modification for female infertility, but eggs you're born with, and they age based on your chronological age. But it's really important to make lifestyle modifications for men because sperm are made 1,000 per heartbeat. And return over every 3 months. And it's an ongoing process, millions and millions per day. So if you think about lifestyle, and it looks like all these improvements that men get from lifestyle changes are epigenetic. So not only does it change the quality of their sperm, but it's heritable. Epigenetic means it goes to the next generation. So I just did a blog on dad's diet affects son's health.
Is that true?
Yes, through sperm. So extremely important that men are healthy to be fertile.
Absolutely. And Paul, by the way, I read that late last night to get prepped because I've heard so much about you, all great in this field. And I just
It's
wanted to
just my
make sure that
mom.
I
My
was
mom's
up
been.
to snuff. But that blog on epigenetics was the clearest explanation of epigenetics that I've come across. And I think you need to like publish that more widely. And I think hopefully, put it
I
on
got a ton of them, Janet.
put
I
it, put it
got a
on a
ton of them.
billboard. So I think because a lot of men come in saying it's, there's nothing I can really do. So why are you telling, can I just stop drinking at the time of the IUI or at the time of the retrieval? And I'm like, no, this takes a little bit more effort.
Yeah, so everything Janet mentioned, recreational drugs, think of your body as a temple and you have to take great care of it and you have to surround your genitals with health.
Okay.
And the same things that make you healthy make your sperm healthy. So and the other concept that people don't understand well is if you surround the male genitals with health, perfect health, they will run hard for you. It's like an engine that wants to run hard. It doesn't want to run. So the classic question is, my sperm count's low, or how can I increase my sperm count? And the answer is stay healthy, because if you leave it alone and surround it with health, it will run as hard as possible in fifth gear at the highest RPM possible.
I'm telling you that people like me don't think that this fertility problem is fixable or can get better by men don't. So
Right.
when my wife when we were going through fertility, she changed everything, right? She quit drinking coffee
Better
and
diet,
wine
yeah.
and better diet and did everything to the point where it actually vexed her, probably in the stress that she wasn't able to to spiritually conceive, almost like she was really stressed. And I'm over here smoking weed and eating whatever I want and doing whatever I need because it was her problem, right? So but then we find out it was. So we are treating a woman for a man's problem. That's a common thing that we keep saying here, that doesn't happen. It's
Only
not-
STDs, right, Janet? The only other time in history that you'll treat the opposite sex for your problem
Exactly.
is STDs.
And so we were talking earlier before you came on, actually, we were talking about taking pills for erectile dysfunction or for premature ejaculation, and that we just want a pill as opposed to actual physical therapy, actually doing the medical things that the doctors can tell us. We don't believe you, or we might believe you when you say eat healthy and exercise, but we don't do it. I'm saying, well, I don't have the sperm so I need to take a pill, or...
So I would double the value of lifestyle changes, diet, lifestyle modification for men. Women do a good job. Men don't do a good job, but it's double the value if a man does a good job. So, pot use. So pot will affect your count, your motility, the shape of sperm, and deeper, it affects the quality of sperm, DNA quality, not mutations in chromosomes, but other things. And the bad news is you smoke pot or toke or whatever, flowers, and then you feel something, you feel better later, or you feel different or back to normal, but it sits in your fat and recirculates for a while, for a couple of weeks, and it comes back. And there's always this low level of toxins going on. Nicotine, not as much, but still bad. So even things like that. And then, I did the hot bath study. Terrible for you.
You mean you don't do it? You can't take a hot bath.
So you can shower all day. But when you dunk your genitals under hot water, it goes a centimeter into your body. The heat effect, I did a lethal dose analysis after my hot tub study. It was picked up by the New York Times, actually. It was not one of my better papers for quality, but they were fighting me. The editors were saying, we already know this. It's not important. I pulled men out of hot baths, watched their sperm counts go up like 400%. And I said, well, I don't know if it's ever been published. I said, well, we don't think it's important. So I went to the Brazilian Journal of Urology somewhere, and they were really happy to have it. New York Times picked it up, put it out there, and they said, pick your contraceptive. You can the birth control pills, you can use a condom, or you can sit in a hot bath. So from that study, I calculated a lethal dose. What I mean is a dose of tubbing that would make a man's sperm count 0. And from the we did dose, duration, frequency. And that was probably 20 minutes, 3 times a week at 104 degrees for a month or two. You're 0. It's like a vasectomy.
Isn't that that's a common thing that couples are doing in a hot tub every night. They sit down.
California, Rob.
So are there other? So yes, this is picking up on trends in male fertility health and things that we kind of hear, but I'm glad you're saying the literal things like you can't sit in the tub. Can you all talk to me about the environmental pollution thing that's happening right now, and that's kind of in the story, and I want to know if that's real or not. Is that affecting my sperm and my fertility?
Well, I think Paul is probably more the expert here on the sperm impact, but I do counsel patients about the risk of phthalate exposures, bisphenols in certain plastics. Again, if you touch a receipt that's coated, don't freak out, but trying to make sure that you minimize exposure, because could that potentially affect your fertility as well as your future pregnancies? Potentially, there are some articles out now on looking at that. And I believe also, and Paul, please interject and correct me if I'm wrong, that it also does adversely impact sperm quality.
Yeah, I mean, this is a really complicated topic. George Halleck's a colleague in Brazil, in São Paulo, which is a heavy pollution place. And a lot of the studies look at associations between sperm counts and exposures like that. And they're epidemiologic studies, so they're statistical. And there's a lot of other things you can't control for. So they do suggest that pollution lowers sperm counts. A new study came out of Denmark, I think a couple of days ago, that looks at pollution in male infertility, and it was sound pollution for female infertility. So apparently noise levels affect or associate with. So I don't understand a lot of those mechanisms. These are association studies. I tend to be a little skeptical because it makes sense somewhat, but because they're not causal, and they never make the next step and show, well, we did an animal model and showed this, or the biological mechanism is this. Now, having said that, I'd say the word epigenetics again. This is probably what's happening with plastics and bisphenols and BPA. Men, I've always thought, have an exposure window that's really important, which is fetal. So when a woman's pregnant and smoking cigarettes, that fetus can be affected by estrogens and things like that when the testicle's forming in the first 12 weeks of fetal life. So it has to form, and there are association studies of maternal beef consumption and estrogens with infertility in their sons. Shauna Schwan did that like 20 years later. So some of those are pretty compelling. And that's a window of disruption. I see endocrine disruption that's really important for men. But then when you get to sort of puberty, I was like, well, it's just kind of running now, and it's being made every couple of months. So, but now I realize epigenetically it could affect it. So microplastics and things like that could have an influence. And it's sort of coming together because mechanistically it's making more sense to me. The association studies have been going on for years. But it's getting me a little more worried, and I don't really need more gray hair.
Can I actually ask?
Dr. Choi, anything to add there?
Well, actually, I wanted to ask, because patients will oftentimes, both women and men, will ask about, is there any benefit taking certain vitamins? And, on the female side, folic acid at a certain dose, 600 micrograms, 400 micrograms a day, to reduce the risk of neural tube defects in their offspring. But what do you think? What's your opinion, based on your research, on vitamins for men? Because there are a few there out on the market to promote better sperm quality. Do they really work?
So prenatals for men is the question.
Good question.
And, Jan, I have a disclosure. I have one. So alpha sperm is mine, but it's so. I would say at a high level, and I just wrote a white paper on this. I modeled it after Satoshi's Bitcoin paper, the Bitcoin white paper. It's a beautiful piece of work.
You got way over my head on this.
Okay,
right
well,
here.
Satoshi's a guy who wrote the white paper on Bitcoin. It's all over, and it's kind of the model, and it's beautifully done.
All right.
So I modeled after that.
Okay, good. Smart.
But what I learned from studying everything is that if you look at men on antioxidant supplements, which is the main ingredient of nutritional supplements, you don't really see a big change in semen quality in the semen analysis or things like that. Measurable things, descriptive factors, you don't see much there. But if you look at fertility potential, and there's a lot of evidence from Cochrane reviews, which are kind of it's a group in England that analyzes fields to see what's needed and what's not been done. It looks at all the data, and they do what's called meta-analyses. They've done 4 meta-analyses over 15 years, each time showing that there's benefit to fertility potential in IVF couples. You get higher pregnancy rates and you get lower miscarriage rates, and more recently, higher live birth rates. These are the measures we use. And they did one, and they said it showed an increase with men take this in randomized trials. They did a second one, it showed it not as much. They did a third one and a fourth one, and they kept doing it because they wanted to show the opposite, but it kept showing positive results. So I would say that the fertility benefits appear to be there, and the semen analysis benefits appear not to be that obvious. So the question is, what's going on? How can that happen? And the answer is that I think it's deeper than that. I think it's going to be DNA fragmentation or epigenetics. We have shown that at least my supplement, taken for 9 months, dramatically alters the epigenetic profile of sperm.
Okay.
So I think there's value in it.
Right.
But I think there's more value in diet and lifestyle. So I think if you have a great diet, that is the thing.
So I want to make this point, and what I'm hearing too is that I want every man to kind of understand and hear. These are counts, like we're saying sperm count,
right?
Where we're looking for one sometimes, or you're literally looking for one, or you're looking to see that this guy can actually get somebody pregnant. Right. And we're talking about egg count, right? Yeah. And your wife is 38 years old. She's starting with what she has, and everything you all are saying is to maximize your count, would you say, or your ability to get pregnant? So when you say vitamins too, the first thing I think
we want babies,
right? But so ultimately, I think in medicine in general, coming from just a layperson, this holistic approach, and to think of the things of the more healthy you are, the better you are at fertility. But at the same time, I love hearing doctors say it's also not the story in that you were meant to have children or not meant to have children. You literally, this is data; these are counts. And it's good to hear you all kind of a bit not have the emotion behind it, but the facts that
I don't think Janet and I think that way. I don't think we think about it. We think we're big picture people, and we're complete optimists.
What I really like is, from again just having this conversation with Paul and with you, Rob, and just sort of sharing my thoughts is our goals in trying to be good doctors or provide excellent services for our patients so they can see good doctors is trying to figure out first what's really going on. Are there things that doctors can coach patients on to try to make material changes so that if possible they can either avoid treatments altogether, or if they do need fertility treatments to have a child, hopefully minimize the exposure to treatments, because it's not that they're unsafe, but they can be costly, especially if you don't have insurance coverage. And they're also emotionally costly, both to the man and the woman in a couple struggling with fertility. So anything we can do to, get you from the doctor's office and out with the final goal of having, after that, whether you need treatments or not, a healthy baby, that really kind of is what matters.
That reminded me of the technique that you do, and I know that, and that is sperm mapping. Yes. We've talked about it, which is what I call, or you call, GPS
of the testes.
Of the testes. And so, tell me about sperm mapping and how and what it's doing.
Well, there are men. 5% of infertile men have no sperm.
Okay.
We call them sterility. We don't use that word very much, but it's sterility. Azospermia is the formal term. Azospermia. I don't know.
But we would say in the old days, we say they're sterile.
Yeah.
Right.
And we know that you make more sperm than you ejaculate now. Okay. So if you make 1,000 sperm per day, you ejaculate 0. You're sterile. If you make 1,010, you may ejaculate 10 sperm. Mm. So there's a reservoir of sperm in the testis, which you can take advantage of. And so some men are blocked and they're 0, and those men, some can be fixed and some can't. So that's a group that can be amenable to microsurgery.
Okay, so then what do you do?
So you would do like equivalent of a vasectomy reversal with a microscope and rebuild it. So I love those cases.
Okay.
Those are the Olympics of microsurgery. Very small stuff. And you can connect tubes that weren't connected and things that are blocked in the system because it's post-production. So it's not a testicle problem. It's an exhaust problem.
Yep.
So I'm a Midas guy.
I think I have an exhaust problem.
Right. I wasn't going to say that.
You can say it. I am the I'm the cadaver on the table.
The banner boy for exhaust problems. And then there's another group, which is most of them actually, who don't have an exhaust problem. The exhaust is fine, and Midas people don't help, but you have an engine problem, so you need a mechanic. But you can't really fix a lot of these men because a lot of it's genetic. So you're stuck with it. But the question is, can you find that reservoir of sperm? Now that's neat, but the reservoir is in pockets. So you don't find sperm everywhere. So if you do a random procedure on a testicle that's sterile, you probably will miss it. You'll miss the pocket of sperm. If you can find that pocket, you're good to go with IVF.
What's a random procedure? So I think the men and women in the audience need to understand the level of what this happens.
So the classic procedure to look for sperm in these men with testis failure is a biopsy, which is a skin cut into the testicle. You send it off to a pathologist like you would anything else of tissue biopsies, and they come back with a pattern.
Do you go up? You go inside and grab it, or just on the outside?
Inside.
You go inside and grab a chunk and pull it out.
Cut it off.
That doesn't sound okay. Keep going.
Yeah, well, you know, it's
I'd like to
it's
avoid
about 75 years old, and it's been the standard of care.
Okay.
And then so that's the basic thing. But you'll get sperm sometimes in those men, but not a lot.
Okay.
So 30 years ago, I saw a bunch of men like this whose biopsies showed no sperm. We came up with advanced ways of looking for sperm.
Got it.
So in New York, excuse me, Janet, but in New York they said, well, let's make a bigger incision. Let's make a really big incision in that testis and open it up like a book and bivalve it under anesthesia and search for the pockets.
Okay.
And because of the influences in New York, that's bigger, better, that's what they do. And in California, I worked with a Swedish group who sticks needles in things. Okay. And so ours is called mapping, and it's non-surgical. And the woman, Britt Marie Young, who taught me this, said, we do this for, here's an example of the difference. Kids with eye cancers called retinoblastomas have, they can make the diagnosis in two ways. You can take the eye out and say, yep, that's a retinoblastoma. Or what they were doing at UCSF, where I was, is sticking needles in the cornea, diagnosing it in situ where it exists, and then treating in situ and saving the eye.
Okay. Yep.
So I said, if you can do that to an eye, and that's pretty benign, right?
Yeah, this is awesome.
You getting uncomfortable?
No, I'm saying you're comparing eyes to
faint?
testicles, and I think it's pretty smart.
Okay.
Because they're on the level of sensitivity and everything. So keep going.
But you're okay. You're not.
Yeah. The guys that are doing this on eyes can do it on my testicles.
Yeah. But you're okay?
I'm okay. Keep going. I'm a little uncomfortable.
So mapping is a way to use needles through the skin under local anesthesia to figure out where those pockets are before you go in for a big procedure.
Okay.
So it's 2 steps, not 1.
Yep.
And it's very effective. It's very safe. It takes an hour, and it's GPS in a sense that you're going to learn what's going on before you before you go.
Okay. And Janet, if you have any questions too, of course. But so the difference, just so I understand, you said that they slice open and like a book, the 75-year-old, and they look, or they take a biopsy and they look.
So that's a biopsy, 75 years old.
Okay.
They look.
So we go in and we find it, and once we find one in a pocket, and I'm just saying, you though, instead of cutting and looking, you're doing pins, you're doing needles.
To find the pockets.
To find the pockets.
Like GPS.
Yes, and then you go in and know. So the point is, when you go in, you're going in that one as opposed to just kind of looking around.
So the microdissection approach based in New York, which is very popular, is blind. It's a blind approach. The mapping is targeted. So you don't necessarily need that big procedure to find sperm if you have a map to work with.
Love it.
Right. So I think it's like with the eye case, it's testis preserving. And it's informative. And if you don't have sperm on a map, no one's found it. So you get good information either way. If you have it, you're on, and the ability to get sperm after those maps show sperm is in the 90 to 100% range. So you're going to get it. You very rarely use donor sperm. IVF cycles, you're rarely freezing eggs. And if you go to IVF with the blind procedure, about half the time you're going to be doing something else, maybe unnecessarily. Mm-hmm. So having the information, the false negative rate, it's true, or the false negative rate means is what I'm saying true, or is it right? So
yeah. So Janet, for you as the CMO for Progyny, you hear this and probably think, well, that's the care I want to give my patients, not be more directional.
I mean, economically.
Okay, yeah. So tell us what you think. What is your perspective on sperm mapping and how it affects the men that are going to be your patients?
So I think, the key thing is making sure that men have access to experts like Dr. Turek, like other reproductive urologists. And by the way, actually, as a fellow, got the chance to see that bivalving procedure. And it is, once you're in there, I mean, it's pretty remarkable. The gentleman is under typically spinal and awake behind the sheet. And they're literally looking through, and again, I might have the anatomy wrong, but the tubules trying to find dilated areas. But what I really appreciate about the mapping that Paul has sort of kind of developed and described is the aftermath, because it's not just, the testicles as sources of sperm and baby making, but also overall, health long-term afterwards. And from my reading, it suggests, and again, Paul knows much more about this than I do, is that the male hormone production capacity to make testosterone is less impacted when you undergo this mapping procedure, which I find really interesting and also sort of the optimal way to try to support men who are going through this process.
Yeah, you're saving the eye.
That's what it sounds like. It's really smart. Janet, what would you want to say to our audience? I mean, I know you have boys. And I have 2 boys too, and part of the mission of this is to communicate this stuff. So yeah, I don't like talking about splitting my balls up. That's not fun. And I don't like talking about men who lose their testosterone because of it, or that couples break up because of the mental anguish that they're going through. And yes, it's hard for my wife to stop drinking wine and coffee and go through all the things that she did. But at the same time, I didn't realize that the men that are going through fertility treatments or dealing with it on their side are going through something so invasive and hard, and they can't talk about it. So from a mom's perspective.
From a mom's perspective, again, they're, I think, at least a decade or 2 before they're ready to start having kids intentionally. But it starts with health even as a child and as a teenager. And so I think I already shared with you beforehand, I'm very comfortable having honest medical conversations with my boys. And so once they hit high school, actually even a little bit before, because I knew they were getting sex ed in school, but not in great detail, I said to them, you realize what happens if you don't have sex without a condom. You realize what happens when you drink constantly or smoke marijuana. And let me just show you the impact if you need a visual of STIs like condyloma. And so I showed them some Google images of penile condyloma, and they're like, that is just way too much, Mom. And they walked out of the room. But I'm hoping that's
shock value.
Keep condoms handy wherever they go. But I also think they're very well aware, because I've heard me discussing not like specific patients, but the trauma that couples experience as they struggle through infertility. And my hope is that that'll translate to, should they decide to have a child, whether alone or with a partner, that they'll know, one, to make sure to look up for their health, not again just for the reproductive part, but just for long-term aging and wellness and health in the male, but also be very supportive of their partner. And again, I think I also mentioned one of my major pet peeves is when a heterosexual couple knows they have infertility, and then the female patient shows up alone, and I'm like, all right, where's your male partner? And if they don't have a really good reason, it's frustrating, because then we're only kind of dealing with half of the potential issue, and we're missing very crucial data points where we can actually intervene and make some real changes. So my wish is that all men would recognize that fertility, if this is to their interest, really is impacted by what they do to their bodies, and they actually have control to make some positive changes over a short period of time, actually, too.
Yeah, I think that's admirable. Tell your kids that you're part, it's a team sport. So if you're going forward, you get involved early on. You don't sit back and smoke pot. And what did you do?
Ate myself into oblivion. I think you guys are already world changers in the medical field, but I'm saying that the messaging is going to be important. You just said, look, I'm happy to talk to my boys about contraception or STDs, and honestly, the negative kind of, we don't want to get somebody pregnant when we're a teenager, or we don't want to get an STD. But what you're talking about is going to evolve into a conversation with our kids about fertility, right, about the future of them taking care of themselves. Why? Because then when they wake up and they're 35 years old and trying to have a kid, and they realize they can't with their wife, and then there's a problem because they didn't, I'm just, we've talked about on the show, women are handled or seen by a medical doctor from 12 on for their sexual health, and
right.
we're
Men
trying
have
to
nobody.
do the same.
Yeah.
So,
but the 2 points Janet made are, one is stay healthy. It matters in lots of ways, in athletics and stuff, but also maybe something you don't care about in the future, like fertility. But also be a team player in a relationship and get involved early, because she was saying that, a lot of the women show up alone, and that can be fixed. That's an important part.
Well, Jana, we really appreciate you joining us today. I'm excited and grateful for Progyny for putting their money where their mouth is, in a sense, and for doing the research to find out the future of fertility for men and for women, and at the same time realizing that a third of the problem is men and that we need to address it. So being in that conversation is going to be world-changing for people, and I want you all to know that.
Your bucket list thing for me is helping men in their fertility battles. That is a huge thing for me, and I'm so proud to be part of one of the architects of that Progyny policy, because it's just it's so important for America.
Any last words, Doctor?
I just want to say thank you to you both. It's a real honor to get to meet and talk with you, Paul, and also a real honor to be able to hear your story, Rob, and see what you're trying to do to help other men in the community. It makes a huge difference.
Okay. Well, everybody, thank you for joining us on the show today. Like and subscribe and make comments about Dr. Janet Choi and her deep, dark coffees. We're going to start a rumor here. Thank you so much, everyone. We really appreciate it. Take care. See you next time.
Thanks for joining the Talk with Turek podcast. Today's show was executive produced by Rob Clyde and Jennifer Harris. DP engineered and edited by Drew Unser. Thanks to Avery Clyde, Shen Heckel, Max Flora, and Jonathan Raju. Talk with Turek is produced and recorded in Los Angeles, California, in association with Hey Babe Media. Subscribe to our show wherever you listen to podcasts and watch us on YouTube. For more information or to book an appointment, whether in person or virtual, visit Dr. Turek online at theturekclinic.com or call 1-888-TUREK-MD, TUREKMD. Don't miss our next episode as we delve deeper into men's fertility and sexual health on Talk with Turek. And be sure to follow us on Instagram and Facebook at Talk with Turek for updates and more content.